Welcome to This Explainer. Today, we're exploring the unique, incredibly high-stakes world of hand and wrist orthopedics and sports medicine. This isn't just about bones and joints. We're talking about fine motor control, wildly complex biomechanics, and the intense reality of treating athletes whose entire careers, literally their livelihoods, rely on a single millimeter of perfectly aligned bone. If you've ever wondered how the delicate anatomy of the hand holds up against the extreme forces of sports, well, you are definitely in the right place.
Okay, let's dive right into our anatomical descent. Today we'll be covering 1. The sports medicine dilemma, 2. Finger fractures and dislocations, 3. Metacarpal bone injuries, 4. The complex carpal bones, 5. Distal radius and ulna, and 6. Trigger finger and nerves.
Section 1. The sports medicine dilemma. Let's begin by addressing the incredibly intense pressure clinicians face when treating high-performance athletes. Now, consider this single, staggering statistic for a second. An astonishing 25% of all sports injuries involve the hand and wrist. A full quarter. Think about it. Your hand is essentially your body's primary defense mechanism. If you fall or if something is flying right at you, pure instinct dictates that you throw your hands out to protect your head, right? Because of this, the delicate anatomy of the upper extremity just takes the absolute brunt of the impact in sports.
But treating an elite athlete? That's a completely different ballgame from treating the average person. We run into this profound philosophical dilemma, which is perfectly captured by the concept of the commodification of the body. In professional sports, the athlete's body is a highly valuable financial asset, and this creates massive tension. Biologically, tissues just need time to heal. But financially and competitively, coaches and sponsors are demanding that the athlete return to play immediately. So, as a clinician, you're constantly caught in this tug-of-war between prescribing the proper rest needed for biological healing and the intense external pressure to get the player back out on the field.
Section 2. Finger fractures and dislocations. Moving down to the digits, we're going to look at the complex injuries that can completely derail a hand's fine motor function.
Let's start with the fingers themselves. What we're looking at here are common phalanx fractures confirmed with orthogonal radiographs, which is basically just a fancy way of saying X-rays taken from different right angles. Now, while a broken finger might sound kind of trivial to some folks, in orthopedics it requires meticulous attention. You see, the hand involves highly complex movements. We aren't just looking for basic stability here, we need absolute precision. Even the slightest misalignments in a phalanx fracture can restrict movement and completely destroy the intricate function of the hand.
Now let's look at the stark contrast between two very famous tendon injuries, mallet finger versus jersey finger. A mallet finger happens when the extensor tendon is disrupted, usually right at the distal interphalangeal joint, or the DIP. The finger drops into a 45-degree flexion and the athlete simply cannot actively straighten the tip. It just droops. Conversely, a jersey finger is a flexor injury. Picture this: an athlete grabs an opponent's jersey, the opponent violently pulls away, and the flexor tendon literally rips right off the bone. Two completely opposite mechanisms, but both absolutely devastating to hand function.
Then we have what is notoriously known as coach's finger. This is a dorsal dislocation of the PIP joint, that's the middle knuckle. It's caused by violently hyperextending the finger, which ends up ripping a crucial stabilizing structure called the volar plate. Without that volar stabilizing force, the phalanx bone just rides up dorsally. It's an injury that requires really careful reduction. And here's the kicker: you must avoid pulling with longitudinal traction, because doing that can actually make it much worse.
Section 3. Metacarpal bone injuries. Moving proximally into the hand, let's examine the metacarpal bones.
The metacarpals make up the structural palm of your hand, so the crucial point to remember here is how we assess them so differently than, say, leg bones. Because the hands don't bear the weight of walking, metacarpal fractures can actually tolerate a little bit of angulation. However, they have absolutely zero tolerance for rotation. If a metacarpal heals with even a slight rotational twist, it causes something called the cascade sign. Basically, when the athlete goes to make a fist, the affected finger will cross over and dangerously overlap the neighboring finger, completely ruining their grip. Not good.
Let's look at the thumb metacarpal specifically. Here, we're contrasting two classic injuries. Over on the left is a Bennett's fracture. This is an avulsion fracture right at the articular surface of the thumb base, which is complicated by the muscles constantly pulling and subluxating the bone out of place. Then, on the right, we have a Rolando fracture. This is basically a Bennett's fracture's much nastier sibling. It's severely comminuted, meaning the bone is shattered into a Y or T shape right at the base. Now, while some metacarpal injuries can just be casted when a closed reduction fails or if the bone fragment is sizable and unstable, surgical intervention becomes mandatory. Surgeons will often use K-wire pinning. It's a very common surgical fixation method used to lock those metacarpal fragments perfectly into place, ensuring the athlete can regain total structural integrity.
Section 4. The complex carpal bones. Let's step up to the wrist now and see how this builds into the incredibly dense anatomy of the carpal bones.
The undisputed troublemaker of the carpal bones is, without a doubt, the scaphoid. It's the most common carpal fracture, often happening from a fall onto an outstretched hand. But the scaphoid has this treacherous biomechanical secret, a retrograde blood supply. That means blood flows into it backward. Because of this, fractures carry a highly dangerous 10% non-union rate. That means the bone simply refuses to heal, putting the patient at risk for a condition called avascular necrosis, which is literally bone death. And to make matters worse, scaphoid fractures often hide on initial x-rays, making them incredibly sneaky to diagnose.
When the ligaments holding these carpal bones together tear, things fall apart fast. And the most famous indicator of this is the Terry-Thomas sign. If the crucial scapholunate ligament ruptures, the scaphoid and lunate bones drift apart, leaving this massive dark gap right on the x-ray. In a bit of brilliant historical clinical trivia, it was actually named after the famous 1950s actor Terry Thomas, who was super well known for the prominent gap between his two front teeth. Kind of a perfect analogy, right?
Another incredibly elusive wrist injury is the hook of hamate fracture. You'll see this pop up heavily in racket sports or golf, where the base of the club or racket repeatedly strikes the palm. It's notoriously difficult to diagnose and is a major source of chronic nagging pain on the ulnar, or pinky side of the hand. If missed, this fracture can actually severely compress the nearby ulnar nerve, absolutely devastating an athlete's grip strength.
Section 5. Distal radius and ulna. Let's step back to the larger foundational bones of the wrist joint, the radius and the ulna.
When the distal radius breaks, a surgeon can't just slap a cast on it and hope for the best. They literally must mathematically restore 3 specific anatomical angles: the volar tilt, the radial height, and the radial inclination. So the absolutely crucial point here is that failing to restore these 3 indices alters the entire biomechanics of the joint, completely preventing the athlete from performing properly.
To understand exactly why, let's look at just one of them, the volar tilt. The distal radius naturally tilts slightly forward or volarward. This tilt creates the physical space required for your wrist to actually bend forward in flexion. If a fracture heals without restoring that specific tilt, like say if the bone heals flat or tilted backward, the athlete permanently loses the ability to flex their wrist. For a gymnast or a tennis player, that is a literal career-ending mechanical failure. No way around it.
Section 6. Trigger finger and nerves. Finally, we move past the bones to look at the soft tissue mechanisms and nerves that power this entire system.
The hand uses this intricate pulley system to keep tendons flush against the bones. But sometimes this system fails mechanically, leading to trigger finger. It starts with inflammation of the A1 pulley. As the flexor tendon tries to glide through this swollen tunnel, it catches. It feels exactly like hitting a speed bump. Over time, it just gets worse, leading to a painful, progressive locking of the digit where the finger actually gets stuck in a bent position. We see this mechanical frustration heavily in diabetic patients, by the way.
And finally, we have to talk about the nerves, specifically an absolutely fascinating clinical quirk called the ulnar paradox. Now, logic dictates that the closer a nerve injury is to the spine, the worse the physical deformity should be, right? But the ulnar nerve completely defies this. A lower injury near the wrist creates a terrifyingly deformed claw hand. However, a higher, more severe injury up near the elbow actually results in a hand that looks less deformed. It's a true paradox where a worse injury proximally masks the actual severity of the clawing in the hand. Wild, right?
Which brings us to our final thought. With all this incredibly dense anatomy we just covered, from the A1 pulleys to the scaphoid's tricky retrograde blood supply, we have to step back and ask a profound question. As a clinician, are you just treating the fracture on the x-ray, or are you treating the athlete's future? Because in sports medicine, you aren't just dealing with bone alignment. You are dealing with a human being whose entire livelihood, identity, and financial future literally depend on your ability to restore absolutely flawless, functional motion. So what's your priority? Thanks for joining me on this explainer. I really hope it gave you a whole new appreciation for the complexities of the hand and wrist. See you next time.